I had this operation at the top of 2022. It took me a while to recover. However, I shared my story online. My partner and my mum were just like, you just need to share this. My inbox got flooded with women saying they've either been through this or they're going through this. And I thought I have to do something about it.
New Victoria Hospital has actually invested in some new technology and technique that will help with fibroids and other conditions. Is that correct?
Yeah, definitely. We had a project to introduce what is called the tissue retrieval system. These are actually a quite clever invention for us.
There seems to be a trend that they can't see everything.
Exactly. Especially if you've got big fibroids behind them, could be, little ones that are hiding, and that's what had happened. You could only see the massive grapefruit-sized ones and, little ones, but then there were loads. And they didn't take out 6, they took out 16.
Right.
That was a massive shock.
Could you explain to me a little bit about all of the treatment options and what a fibroid sufferer should be looking for from their specialist?
Why is there such limited clinical evidence about fibroids?
The biggest percentage will experience the worst symptoms in perimenopause. So once you are in perimenopause, definitely hysterectomy is the most effective treatment.
That's interesting. That segues into my question. So you do get some women who say that they do suffer after menopause with fibroids. There's been quite a few ladies that I've spoken to. So why is that?
Welcome to the third instalment of JFPR's Breaking the Silence Health Panel discussions. I'm Juliet Francis, the founder and director of JFPR. Recently, the government's health secretary announced new priorities to bridge the gender inequalities gap across healthcare, following a number of reports, including one from the Royal College of Obstetricians and Gynaecologists, Better for Women report, that found that women cannot always find accurate information about their health condition, that healthcare remains largely an intervention, not a prevention service, and opportunities are missed to empower women and girls, and that healthcare services are fragmented and difficult to access. At a time where your health issues may take longer to diagnose due to waiting lists, or you're struggling to find the right pathway with your GP, our Breaking the Panel discussions are here to deep dive into some of those underrepresented conditions, whilst helping you navigate your pathway through healthcare. So we have 2 special guests joining us today. Dawn Hills, fibroid advocate and influencer, and Miss Silvia Carta, fibroid specialist and gynaecologist of New Victoria Hospital based in Kingston, Surrey. Guys, really great to have you both here. Thank you so much for joining us on this panel discussion. So thanks so much for joining, Silvia. Really happy to have you here. It's a really actually interesting condition that we're talking about today. Uterine fibroids. Could you tell me what they are and sort of what types of fibroids that people actually experience?
Yes, uterine fibroids are benign tumour and are actually the most common benign tumour in women. There can be different types of uterine fibroids, so leiomas as they are also called, and they vary primarily in the composition, so they can have a little bit more fibrotic tissue, a little bit more adipose tissue, a little bit more muscular tissue. But what makes really the difference in them is the location and the size of them. So they can be inside the cavity, they can be just touching the lining of the womb, they can be inside the thickness of the muscle of the womb, or they can be on the outside part of the womb. And they can be also in the neck of the womb, which is the lowest part of the womb.
Thank you so much, Dawn, for joining. Really happy to have you here. I know that you have actually struggled with fibroids yourself previously, and so could you tell us a little bit about the journey, also the fact that you've become an advocate, for other women suffering from fibroids, why you're so passionate about talking about it, and what you think, some of the myths are that people think about fibroids?
My journey started at 14. I had very heavy, painful periods. And I went back and forth to the doctor about that, but I was told this was normal, that you'll get lovely periods when you're older. It's just you being a teenager. But when I reached my 20s, I found that my periods were just awful. So I went onto the pill. The pill took away my periods. I was on the progesterone-only pill, and that was amazing. I was living my best life. However, when I reached my 30s and I was thinking about having children in that decade, I came off the pill and I was met with horrendous period pains. Now, when I was about 33, I was at a very horrible toxic workplace. I was experiencing pain in my left-hand side of my abdomen. And I was thinking, what is that? So I went to the doctor and he said, it's probably got something to do with your cycle. I thought, no, this is a bit weird. Went back again. He said, I think it's got something to do with your cycle. So I went to see a female doctor who said, I think it's probably a cyst on your ovary. Let's go and have a scan. I went and had the scan and they found 2 fibroids. They were both 4 centimeters in size at the time.
Can I ask actually, Sylvia, what are the typical symptoms of fibroids actually? What should people look out for if they want to be diagnosed?
Yeah, so heavy bleeding with the periods and painful periods are quite typical of fibroids. Primarily, I'd say probably heavy periods to start with, when the fibroids are a little bit smaller. And once the fibroids become bigger and bigger, also depending on their location, whether they are inside the cavity or in the thickness of the womb or outside, whether they are anterior or posterior or on the cervix, they might give also other symptoms to look at. For example, urinary symptoms, as they might compress on the bladder, on the ureters from the kidneys. You might look for the compression symptoms. They might compress on the bowel. They might give constipation, which is another symptom to look at. So very, very painful periods, or pain during intercourse, that's another symptom to look at. And then later on, they can cause also fertility issues. Again, depending on the location, not all of them, but recurrent miscarriage or single miscarriage and obstetric complications. And how do we diagnose them? Pelvic assessment and overall history taking are a milestone in the diagnosis, and that should then address pelvic ultrasound, which is the first level investigation.
So, Dawn, having had that experience, up until diagnosis, you've become quite an advocate for fibroids, actually, and, sort of basically educating people online, helping sufferers to navigate their own journeys. Can you tell me, what happened after that, a little bit more about that journey? Because eventually you had to face doing something about the fibroids. What sort of things did you not understand during that journey? Why was it a bit of a battle for you, and the myths that people going through that journey would face?
So after the sonographer told me I had 2 fibroids, I went back to my original doctor, and he told me that, yes, you've got 2 fibroids, they're 4 centimeters in size, but they're very normal, very common. There's nothing to worry about. Just take ibuprofen and a hot water bottle just to deal with the pain. And what I found over the next 6 years of my life was me becoming a dictionary definition of fibroids. So I had every pain going. If you look in the NHS guidelines, you'll see. So I had abdominal pain, which was from my left-hand side to my right-hand side, back pain, butt cheek pain, a leg pain that went all the way down to my toe. I was constantly peeing, so my bladder was full all the time. I had to go to the toilet. I felt nauseous. I felt very lightheaded all the time. Very painful, very heavy, clotty periods. One of the worst things was I was actually rendered infertile, and I didn't know at the time it was the fibroids that had caused that. So within 6 years, I kept going back to my GP, and he kept saying to me, this is all normal, it's all common, you just deal with the pain. Now, fast forward to, it was 2021, I actually had private medical health care, thankfully, at work, and I went to see a consultant who, for the first time, listened to me. He understood what I was going through and wanted to know, okay, what is it that you want from life? And first of all, I wanted a good quality of life back, because I literally was planning my life around my periods, and in the end, pain as well. And I also wanted to try for children. So he rescanned me, and he said, you've actually got 6 fibroids, at least 6, the biggest being the size of a grapefruit, because my stomach had actually started to protrude. So if you think about being infertile, cannot have children, and looking like you're pregnant, it's absolutely heartbreaking. So from that, he said, you'll have to have an open myomectomy, which is an operation that almost resembles a C-section, because the cut is similar, but they always say it's deeper and it's like shedding peas. So he said, we're going to have to do that. And I always thought that if I'm having such an operation, it will be because I'm going to give birth to a child, not 2 tumors. So I had this operation at the top of 2022, and it took me a while to recover. However, I shared my story online because my partner and my mum were just like, you just need to share this. And my inbox just got flooded with women saying they've either been through this or they're going through this. And I thought I have to do something about it. And that's where my journey began, with sharing such information, empowering women, supporting and providing information. But one of the biggest myths is that hysterectomy is the only way to deal with fibroids. I see it all the time in my inbox, women saying they've gone to try and sort out their fibroids, and the first option on the table is a hysterectomy, and that is a myth. Unless your life depends on it, like you've got cancer's found in the uterus, there are other options available.
Yeah, that's a really powerful story I've just heard from Dawn, and I'm sure you've heard quite similar stories from some of your patients by the time they come to you. In terms of fibroids, and especially if it's a young woman, and they maybe haven't had children or they want to have more children, and they discover fibroids, how impactful is that on fertility, first of all? And there's other sort of conditions that are linked to fibroids, because apparently there is some evidence to suggest high blood pressure and fibroids, there may be a link. But fertility, let's start with that. I mean, what is the situation with that?
Yes, we've had quite a few studies on fertility and fibroids.
There seems to be a trend that actually they can't see everything.
Exactly. Especially if you've got big fibroids behind them, could be, little ones that are hiding, and that's what had happened. So you could only see the massive grapefruit-sized ones and little ones, but then there were loads.
There are primarily some fibroids that will impact on fertility, and let's say nowadays we have a bit more proof about that, and these are specifically the ones inside the cavity, or even just partly inside the cavity, because they will work like if they were an intrauterine device, and they will also cause inflammation of the lining of the womb and interfere with inflammation and development of the embryo. The situation is a little bit more difficult to explain when we're talking about intramural fibroids, so the fibroids that are entirely in the thickness of the lining of the in the thickness of the womb, because those still might cause some degree of inflammation. But the ones that don't modify the shape of the cavity of the uterus, we think that most likely are not going to interfere much with fertility. And again, for the one on the outside of the uterus, the evidence that there could be any interference with fertility is quite low. So they should be on one side potentially the good ones. Of course, there are other variables to look at in terms of the size of them and symptoms of the woman. So it's not just about the time of conception, but the fibroids in pregnancy, even if they are on the outside, what we call subserous fibroids, in pregnancy, if they are already big, they can grow considerably and make pregnancy quite a difficult time for the woman. So there are many other factors to consider when we want to decide whether we do surgery or not for them, not just the fertility. And your second question was around other pathology linked to fibroids. Yes, there is some evidence that seems to link a little bit high blood pressure with fibroids and black ethnicity in a way. And if you think about that, actually high blood pressure is also much more prevalent in the black ethnicity. So we're thinking, is there a connection of the three of them? We don't really know, or whether this is a bit of a confounding factor. Is there a genetic component behind? So what we have noticed in some studies is that angiotensin-converting enzyme seems to be linked with that, and women who take medication, women who have high blood pressure and take medication to block the angiotensin-converting enzyme, they will then have a lower incidence of fibroids, or at least clinically evident fibroids. So somehow that medication might keep under control the fibroids. So does the angiotensin-converting enzyme has any link with that? But definitely there is a link with high blood pressure. The association is a little bit stronger with diabetes also in terms of other pathologies. And then, several environmental factors have been studied around, also some of them linked with hypertension, for example, chronic stress, as you were mentioning before, very stressful time at work and so on.
Dawn, so yes, I understand that when a lot of women go to the GP or the gynecologists, a lot of them have been offered hysterectomy. But it's not necessarily the final solution, which you found out there are other solutions that you can have. So you went for a myomectomy. Can you tell us a little bit what that was like, actually, in terms of experience, especially if you've never had a child and it's basically similar in terms of having a cesarean? How do you feel about going through that? I mean,
No, it was the worst case scenario for myself. I think when I knew about having 2 fibroids, I thought maybe if they'd grown, I'd have an open, a keyhole surgery, When he told me about 6, again, in my head, I thought maybe keyhole. So when he said open myomectomy, where you're cutting me from one side to the other, it was a lot to take in.
Yeah.
Now, I went and had it, and they didn't take out 6. they took out 16 fibroids. So that was a massive shock. They left 2 in to give me a chance at conceiving, which happened in the July of the same year. So it definitely was the fibroids that was causing the infertility. But it's such a major operation to recover from. It took me about 8 weeks to recover from such, and you can barely do anything. I had an emergency blood transfusion as well a week after because I'd lost so much blood. So it's not an easy a decision to make, but it has definitely improved my life 360. It really has.
I've got to say, I'm hearing a few incidences of people going in for surgery, myomectomy, and coming out and having double the amount they were diagnosed with. I don't know if you've heard.
Absolutely.
So it means that, you know, well, it doesn't necessarily mean that what you're being diagnosed or how many, it's probably more, but there seems to be a trend that actually they can't see everything.
Exactly. Especially if you've got big fibroids behind them, could be, you know, little ones that are hiding, and that's what had happened. So you could only see the massive grapefruit-sized ones and, you know, little ones, but then there were loads.
Yeah.
There were loads.
So hearing that a lot of women who go and have diagnosed with fibroids feel that one of their main options is hysterectomy, but you know there seems to be myomectomy is obviously another sort of second choice. Could you explain to me a little bit about all of the treatment options and you know what a fibroid sufferer should be looking for from their specialist when they go and the options available to them?
Yeah. So actually, we have quite few options available, different from hysterectomy. And I think the most important part of the treatment is to discuss with the woman and try and understand what is most suitable for the woman in the context of what is safe for the same person. So we have several medical options available. Dawn's already mentioned before about contraceptive pill, the progesterone-only pill, and that actually works quite well for several years until when the fibroids reach a decent size, and if they don't cause pressure, because that will mitigate only the bleeding and painful aspect, but the pressure symptoms, the pill won't be able to take it out. Similar treatment, but just through what is called the intrauterine device, is the Mirena coil that releases progesterone and actually can even shrink the size of the fibroids minimally. Not a massive reduction in volume, but a minimal reduction in volume, yes. And by reducing also the blood flow, it reduces some of the symptoms like the congestion, the pain, and definitely the bleeding. Of course, that's not suitable for everyone. So some women would not like to have an intrauterine device for just personal preference sometimes, or sometimes it just doesn't work for them.
So I just ask how the device works. I mean,
yeah, so it's specifically what is called as a modified release device. So it has a T-shape that is inserted inside the womb through a very, very small cannula. And that can be also done under local anesthetic for women who haven't had children before, that are particularly sensitive to the pain that can come from a little bit of dilatation of the neck of the womb. And it goes through the vagina, through the neck of the womb, inside the womb, and it stays in the womb for a few years, releasing progesterone. So the same progesterone that women would take by mouth, alternatively can be delivered in the womb where it's needed, with very minimal stimulation on the rest of the cells. Because remember, on the other side, some women might have quite severe effects of the similar medication, which is a progestogen medication. And by giving it through an intrauterine device, it will only work or primarily work in the uterus without giving significant other side effects.
okay.
Then there are other medications. Combined oral contraceptives have been used, but they are less effective than the progesterone-only pill. Some medication were tried in the past, and they are still on the market. One of them is called smear. So you might have heard about smear, which was a little bit in the press because of it can cause liver disease, severe liver disease and liver insufficiency. But it's actually quite effective in the treatment of fibroids. So it was initially withdrawn from the market, and now it's again, so clinician can use it, but it can be used only as a transient treatment. So let's say someone is waiting for surgery and is having very heavy periods in the meanwhile, just to improve their quality of life in the interval in between the treatment and the surgery, or for example, someone that is just approaching menopause. But so that can be used until the menopause. It cannot be used long term because of the severe risk of liver disease.
Okay. What about sort of surgical options for women?
Yeah, so in terms of surgical options, it depends on the location of the fibroids. Some women will have just 1 or 2 fibroids who are protruding inside the cavity of the womb. And that's actually the lowest risk surgical treatment, because those are very good candidates to transcervical resection of the fibroids, which means that with a camera going through the neck of the womb, through the vagina first and the neck of the womb, we can see exactly how much of the fibroids are protruding inside the cavity. And these are the fibroids that will interfere the most with fertility. So it's a really a good balance in between risk and benefits to try and remove them from down below with this resection of the intracavitary part of the fibroid. The other option, of course, you mentioned myomectomy, which you had, and there is scope for myomectomy, definitely, especially when the fibroids are numerous, bigger in size, and it depends also on the location of the fibroids. There are other techniques that have made the myomectomy a little bit less popular amongst clinicians, and also from nice guidance in terms of the nice advice is if you haven't tried the more conservative methods before, you should try and avoid myomectomy. As we said, it should be more a patient individualized choice. Once the patient is aware of the pros and cons, that should be a proper evaluation of risks and benefits, and then the full decision should be taken in the end with the clinician. The other techniques that I was touching on, focused ultrasound, like high intensity focused ultrasound, where basically we are using ultrasound rays to so ultrasound beams to ablate and basically burn, in simple terms, the central part of the fibroid. That's actually not really that popular anymore, because there is some scope for that, but it will reduce the size of the fibroid by maximum 40%, and the risk of needing reintervention is around 30%, so it's quite high.
So I'm just wondering if this technique is also not necessarily recommended if you are trying for a child, for example.
Definitely. So there are a lot of limitations in this technique. It's not recommended for fibroids bigger than 10 centimeters when they are numerous, and there is not really much evidence on the effect on fertility and whether it's safe to have a pregnancy afterwards, because we don't know about the resistance of the uterus in the area that has been the focus of the beams. So definitely we wouldn't recommend in women whose priority is fertility. And similarly for uterine artery embolization, which is an additional technique, the uterine artery embolization will basically cut off the blood supply through the uterine arteries, which are the ones meant to feed the placenta and the uterus during pregnancy. So there have been cases where there has been a pregnancy post-uterine artery embolization, but there is an increased risk of the baby being small or the placental pathology. So it is not really advised when the family is not complete. Yeah. And then finally, just a quick mention, someone that is available recently is called Rieqo. It's a medication that combines GnRH analog with ethinyl estradiol and norethisterone. So in simple terms, it's something that will induce pharmacological menopause, which is reversible, associated to a sort of ADVEC HRT to mitigate the symptoms of pharmacological menopause. So it's again something that shouldn't be used very, very long term, or in women who are seeking fertility. Yes, can be used for a limited period of time, but it's not a long-term solution to the problem.
When we say limited, because I've had lots of questions on that drug, so when we say limited period, how many months are we talking about?
Well, so if you're using HRT, as Beck HRT, you can use it for more than 6 months.
Oh, wow, okay.
The ones that you're not meant to use for more than 6 months,
Yeah.
the ones where you're not using HRT. We have had, sometimes you need to go also a little bit out of official guidelines and again discuss with the patient pros and cons. So it's not that it's a complete no-go to use it for longer, but then you increase the risk of osteoporosis, cardiovascular disease, and other potential side effects. So that the woman needs to be aware of that.
And what about fertility off the back of that? Because I think that's the big question with any procedure, any drug that we're taking.
For fertility, so it's a reversible medication.
Yeah.
So once your body has metabolized it, it shouldn't interfere anymore with the ovarian function. So the ovarian function should restart as it was before. So there is no evidence that will deplete or endanger ovarian function.
Thank you.
So I believe that New Victoria Hospital has actually invested in some new technology and techniques that will help with fibroids and other conditions. Is that correct?
Yeah, definitely. We had a project to introduce what is called the tissue retrieval system. These are actually, I would say, quite clever invention for us, because one of the challenges we have sometimes is to get into the cavity, into the womb, when the neck of the womb is particularly tight, or similarly, when we need to do transvagal resection of the fibroids, we do have to open the cervix in someone that necessarily didn't necessarily have pregnancies before. And by using this instrument, we can minimize the size of the opening that we need. These devices have a size of 6.25 millimeters in the oldest versions, while the new ones are as small as 5.5 millimeters. And with these systems, we can enter the cavity and quite safely remove the small fibroids or intrauterine pathology that is protruding in the cavity. Of course, there are limitations of those, as they cannot be used for very large fibroids. They cannot be used, for example, for calcified fibroids, because the blade they use is not that strong, not as effective as using the classic resection. The calcified fibroid is a fibroid where there is a solid component that is really similar to stone, like limescale or stone, because especially if the fibroid has gone through a process that is called degeneration. So the fibroids are fed by blood supply from the uterus. Sometimes they grow so much, but the blood supply cannot feed the fibroid anymore. Then the central part of the fibroid will die, and the fibroid, the central part will have this deposit of calcium that will make them very, very hard and difficult to cut through. That sometimes can make a little bit more difficult the resection, hysteroscopic resection of it. And the big application of the tissue retrieval systems is that can be used as an outpatient procedure. So women who have small intrauterine fibroids don't necessarily need to have a general anesthetic and having to recover from the general anesthetic to have them removed, but they can be used in local anesthetic and with a minimal dilatation of the neck of the womb.
That's a really good procedure because, and it goes to the point of, small fibroids can cause a lot of issues. I often see ladies, they will DM and say, I've got these small fibroids, they're causing so much pain, but my doctor or gynecologist has said, no, it can't possibly be that. But that's showing us that they can be problematic and there is something to help.
Yeah, so when they are inside the cavity, yes, it's then quite a big chapter and a different situation when they are on the outside of the womb or in the muscle of the womb, in the thickness of the womb, yeah.
It sounds like it's also similar to a hysteroscopy, I think
It is. It's like, sometimes as clinicians we tend to assume that patients will understand, so maybe we don't really mention it specifically, but it's just a different or an advancement of the classical hysteroscopy using a device that has a different instrument on the tip. So the rest of the system is the same, the camera is the same, the stack is the same. So the other instruments we use are the same. It's just that the camera itself and the instrument that goes at the tip of the camera, they have a different system compared to the classic one.
So a patient that has been diagnosed with uterine fibroids within the room, that's quite small, within a certain amount of centimetres, what sort of 3?
I would say probably up to a couple of centimetres can be done with a MyoSure. I wouldn't probably do bigger. I mean, potentially you can do, but it'll take a very, very long time. And at the point when they are so large, I feel that like the classical transbucal resection will probably be more effective.
Okay, that's interesting, because I know that a lot of patients have not necessarily been offered a hysteroscopy for that. But obviously that's definitely an option if they feel that it can become a problem. But on the flip side, I just wanted to ask, are there any concerns when doing something like this of adhesions, like scarring, etc.?
Yeah, so anytime you have surgery, you have to deal with this sort of potential complications. Either it is a hysterectomy, a myomectomy, or a hysteroscopic resection of the fibroids. With the MyoSure, generally, I mean, of course, there have been less studies because it's a relatively new technique, but we don't use energy. It's just a blind cutting. So the risk of adhesions, intrauterine adhesions, should be a little bit less. Although, as I said, we don't really have many studies in regard. Anytime we use energy device inside the womb, that can be a risk of the walls of the uterus to stick together. And that can be an issue with fertility, because if the walls of the uterus from the inside are stuck together, the lining of the womb cannot grow. And that we need that growth, the lining of the womb, to allow the implantation. On top of that, adhesions can be a trigger for inflammation. And anytime there is inflammation, again, this interferes with the inflammation and fertility.
Thank you.
Yeah. And similarly with the myomectomies, again, it depends. Sometimes if it's a very small fibroid, you have to evaluate whether you might cause more damage by causing adhesions rather than improving the outcome. Yeah.
So actually, I mean, what causes fibroids? I think this is what's probably on so many sufferers' minds, is how can they potentially prevent this? Is there anything, lifestyle choices, and any research actually been done to look at if there's anything within lifestyles that is actually causing fibroids? And how would you recommend someone manage those symptoms from a much more sort of natural point of view rather than surgery?
So there have been quite a few researchers on what actually causes fibroids. Is it an environmental factor? Is it a genetic factor? And as I said, it's really difficult to find a direct answer to that because of the variety that is around the fibroids. Definitely there is a genetic component. You've seen, for example, cases where the grandmother has them, the mother has them, the daughter has them, the sisters they have it, the cousins they have it. There is, as we said, a predominance in the Black ethnicity. And beside this, there seem to be some genes that are more associated with fibroids. So I think it's a little bit like some kind of tumors. There is not a one-to-one relationship. It's not like there is a gene that is fibroid, but it's a combination of genes plus a lot of environmental factors. And indeed, there have been several studies, for example, on stress, as we said, because stress will also cause increase of inflammatory markers. Some studies have found that having a pelvic infection might increase the size of the symptoms of the fibroids. High intake of caffeine at quite young age is another factor that has been identified. And something quite interesting on the levels of vitamin D, which will be like a low intervention, as I say, treatment or preventive treatment. So we think that could be a relation in between vitamin D, Black ethnicity, because of the melatonin will block the conversion of the vitamin into the active form of the vitamin D. So there are definitely several factors. Diet is also another component. High intake of red meat, like beef and red meat, seems to worsen the symptoms of the fibroids. We mentioned already women with diabetes, there is an increased risk, so high glycemic index food increases the risk. So based on all this, what can women do to, I don't think once the fibroids have developed, there is a way to completely revert the process just with natural methods, but definitely there are things that can improve the symptoms, like in general healthy lifestyle, healthy diet, regular exercise. Then of course there is a certain point after which just with conservative intervention it's not really possible to revert or improve the quality of life, and that's at that point where let's say more invasive treatment options should be looked at.
If somebody is actually deciding that they're going to try and manage their symptoms through lifestyle choices, what would you recommend in terms of getting checked to see if that fibroid has actually grown or reduced, or how do you check whether that lifestyle choice management has actually worked? Would you suggest like continual sort of assessments through screening?
Yeah, so of course clinical assessment is one of the first points. Also, for example, keeping a diary of the symptoms might help, because it's more difficult to assess retrospectively, because we might tend, I know that most of the symptoms we might kind of remember them, but going and assess specifically what was happening 12 months ago with everything else that's happening in your life might be a big challenge. So keeping a record of symptoms is already quite important, then analyzing this with your clinician. But also, of course, clinical assessment and ultrasound, pelvic ultrasound assessment as a first line. Then based on this, of course, there are other more invasive intervention or second or third line diagnostic tests, like, for example, MRI. If the ultrasound is not, sometimes it can't really give us a good answer. You mentioned earlier you thought you had 6 fibroids, but then you went to have surgery and you had 16, and that's because, of course, there are limitations of the ultrasound. It's a really great test as a first-line diagnosis, but then it won't give us, sometimes it can't tell us exactly the position of the fibroids, it can't tell us exactly the relationship with the lining of the womb, which is quite important when you have to do surgery, and that's why sometimes we might have to refer to performing an MRI to have a bit more information.
Okay, so in MRI you can actually see a lot more.
Yeah.
That's really interesting. Thank you so much.
So Dawn, I know you've obviously had the surgery, you've obviously had a child since then, but also I'd be interested to know, obviously, the thing is that we haven't mentioned is that fibroids can reoccur, and they do very commonly reoccur as well, which is why a lot of women invest a lot of time trying to find out how they can manage their symptoms. Can you explain what you have been doing and what you've come across in terms of the journey to help manage any more symptoms or try and prevent further fibroids? And also a little bit more about your advocacy, who you've been aligned to, your time at Parliament. I know you've been an active campaigner for this.
So I've done a lot of research. So I've got the 2 fibroids remaining. They are tiny. So thankfully my symptoms, I get very happy periods. So I don't really get bad symptoms like I did. I get a tiny bit of period pain sometimes, but I've experienced pain-free periods, which has been amazing. But what I've come across is this, again, research is very limited, but I came across a small piece of research which said taking green tea extract, so taking green tea, drinking it can actually reduce the size of the fibroids. So that's what they had looked into. So I drink green tea religiously. Castor oil packs, they're really great for the overall body, but for menstrual health as well. So I've taken those and I've seen a reduction in sort of period pain. And just, I don't know, it's really weird. My uterus just feels nice. With the castor oil packs. It's just really nice to do that as well. Movement as well, just going out for walks, like you say, being exercising, green leafy foods as well, all of that, because that all kind of builds that very healthy pictures for the actual fibroids. That's what I've been doing. In terms of advocacy, we are seeking change. So we've talked a lot about guidelines and information, and what I find is that there is not enough information for women. So getting the diagnosis is quick, but what happens thereafter, there can be years and years upon which a woman would wait to get to where she needs to get to. So we go to Parliament, we're asking for more information to be given to these women so they can make an informed joint decision, as we've been talking about. And I always say one of my biggest kind of pieces to women is to educate yourself on the condition, because I find when you walk into a doctor's office or into the consultations office and you say, actually, what about this option for me? I heard that this XYZ about fibroids, I feel like you're dealt with differently. I feel like you are. So educate yourself, advocate for yourself, because like you say, again, just to reiterate the point, it's a joint decision at the end of the day. And I feel like if things like a hysterectomy has been put on the table, but that's not what you want, you've got to speak up. This is your body at the end of the day, and you don't want to do yourself a disservice.
So Dawn, so that's really interesting actually, that you can manage your pathway, and I think a lot of women really, really appreciate the fact that they've got those options. But I know that your followers have asked some questions, and I think we can sort of whiz through those if you can ask Silvia directly what they've asked.
So why is there such limited clinical evidence about fibroids?
Yeah, it's true that there is a limited non-conflicting evidence about fibroids. And as I mentioned, I think this is due to the fact that there is a huge variation, and it's very difficult to do studies where you are comparing the same type of fibroids, the same location of the fibroids, because this makes a huge difference. For example, for fertility, we mentioned you can't compare a submucous fibrous to a subserous fibroid. They are absolutely different, but when, especially in the past, with, I say, less effective diagnostic test compared to what we have now, I think it was really, really difficult to make to avoid bias, if it makes sense. So I think the main reason why we don't have much evidence in regard is that because of big biases.
Thank you. This one is a hot one. So why are consultants often reluctant to act when they find that there are fibroids present?
Yeah, it's of course it depends much on the attitude of the clinician sometimes. Behind this, there might be sometimes evaluation of balance in between pros and cons of treatments. Some treatments can be particularly invasive and can actually, if any complication happens from the treatment, they can actually worsen the quality of life of the patients. Of course, I think nowadays we have moved a little bit away from that's what I think should be done, and that's what we are going to do. I think the attitude should be more, that's what is available, what would be your preference, yes. What can we do for you in the range of what is available. Mm-hmm.
Why is a hysterectomy the treatment option that is offered the most?
Yeah.
And we've had conversations about this because some women feel as though they don't know what to do with me, let's just take it all out.
Yeah, so sometimes they might actually feel like this. So the reason why we have to compare like different treatments options. So if you take hysterectomy compared to myomectomy, for the patient, hysterectomy is safer. If you're talking only about clinical assessment, so what is more likely to cause potential risk of death or potential risk of severe infection, potential risk of very heavy bleeding, myomectomy. What is less likely to cause it is hysterectomy. Of course, then you need to evaluate other things. You can't offer a hysterectomy to someone that says, I haven't completed my family, I want to have a pregnancy. On the other side, if you have a patient who is 43, 44 and hasn't had any pregnancies and is planning to go for fertility treatment, and there are 20 to 30 fibroids in the uterus, and doing a myomectomy will cause the woman to go home with a uterus full of scar, where even if she goes through IVF, she's going to end up with a very, very high risk of obstetric complications and potential maternal death, which we have seen few cases. Then, of course, you're quite reluctant to offer a myomectomy. But again, it's a matter of what is the patient that we have in front of us.
Thank you.
And the other quick answer to that is many women will have their symptoms in perimenopause. So I would say many women will have them because of fertility-related issues, but only not the biggest percentage will experience the worst symptoms in perimenopause. So once you are in perimenopause, definitely hysterectomy is the most effective treatment.
Okay, that's interesting. That segues into my my question. So you do get some women who say that they do suffer after menopause with fibroids. There's been quite a few ladies that I've spoken to. So why is that?
So after menopause, you might suffer with fibroids if you are on HRT treatment, because HRT typically you are giving estrogens, which are the food for the fibroids. So after menopause, the fibroids are meant to regress and shrink down and become quiet and don't cause any more trouble. But if you're taking estrogen, and sometimes the progestogen that you give to balance the effect of estrogen might not be that effective, then you might still experience some symptoms.
Okay, thank you. And the final one, this is interesting. How do you know if your tummy is just bulging because maybe you've put on weight, or whether it's a fibroid? Because I had that. I thought I had put on weight, but it was my fibroid that had protruded the belly out.
Just have a ultrasound. The ultrasound will distinguish, of course, the size of the fibroid, and then by looking at the tummy and looking at the size of the fibroid on ultrasound, then you say, yeah, actually, this is not. If the woman comes with a bulging belly and say, look, I'm 46, 48, I'm going through my perimenopause. Typically in perimenopause, the abdominal fat will increase, the abdominal subcutaneous and fat tissue will increase because of hormonal changes. And then you do a scan and you find that there is a 0.5 centimeter fibroid. It's logical, you can't justify that. But if you have a woman that says, look, I'm being very healthy, I'm exercising, healthy diet and so on, and my belly feels like I'm pregnant, and it grows, and then you do a scan and there is a 15 centimeter fibroid, that definitely is the fibroid.
Yeah.
Yeah.
Thank you. That's my question.
Excellent. Thank you so much. I think we've been really thorough there. Thank you so much, ladies. Dawn and Sylvia, really thorough. That was such an insightful discussion. We're going to have to wrap it up for now. Thank you so much for watching. I hope that you all took away quite a lot of information, and until next time.